Hello everyone, this is Rushil Reddy. In this video, I am going to explain the topic on oral cavity cancer. This video is presented by MEDeaze and MEDeaze freaks. Let's see what are the objectives we are going to learn in this video. They are introduction and epidemiology, risk factors, pre-malignant lesions of oral cavity cancer, tumor staging, pathology, and signs and symptoms. In the next video, we are going to listen about the diagnosis and management part of oral cavity cancer. First, let us discuss about introduction and epidemiology. The oral cavity cancer majorly involves the mucosal surface to the junction of hard and soft palate. This is a region where the oral cavity cancer is majorly observed. When we see about epidemiology, oral cavity cancer is the eighth most common cancer worldwide. The incidence rate is 350,000 cases per year. Majority of them are squamous cell carcinoma type. When we compare the occurrence among men and women, there is a ratio that is 2:1 ratio. When we come to regional epidemiology, it is the most common cancer in India. The reasons can be due to common use of carcinogens like betel quid, gutka, smokeless tobacco, and etc. Now, let's see what are the risk factors which can lead to oral cavity cancer. These are the four major risk factors which can lead to oral cavity cancer: tobacco chewing, alcohol, human papillomavirus infection, and betel quid intake. The other risk factors could be like exposure to any radiations, chronic infections, immunosuppression, hereditary causes, Fanconi anemia, and last can be Lee-Fraumeni syndrome. These could be the other risk factors for oral cavity cancer. Now let's see some of the pre-malignant lesions which are seen prior to the occurrence of oral cavity cancer. Leukoplakia is a white patch which is seen in the oral cavity. It can be a patch or a plaque which can be rubbed off. Whereas erythroplakia is a bright red velvety plaque. Erythroleukoplakia is presented with both leukoplakia and erythroplakia. The other pre-malignant lesions can be proliferative verrucous leukoplakia (PVL), oral submucous fibrosis, oral lichen planus, lupus erythematosus, and dyskeratosis congenita. Among all these lesions, the erythroleukoplakia, proliferative verrucous leukoplakia, and dyskeratosis congenita, these three have the maximum risk for malignant transformation, which means they have the high tendency to convert into a cancer. Biopsy of these lesions can be done for accurate pathological diagnosis. Biopsy. This is done to rule out presence of any malignancy or to know the degree of dysplasia. Now let's see the tumor staging of oral cavity cancer. Tumor staging of any cancer is done by a system called TNM system, which means T for tumor size, N for any lymph node invasion, and M for any metastasis. T staging can be done by routine clinical examination, CT or MRI, or by seeing depth of invasion. The depth of invasion can be known by radiological examination. N staging is seen for any lymph node invasion, and in case of squamous cell carcinoma of oral cavity, there is a high tendency to metastasize to level 1, 2, and 3 lymph nodes of the neck. Whereas in M staging for distant metastasis, there is routine assessment of chest for any evidence of distant metastasis. Then comes the pathology of oral cavity cancer. Under pathology, the histological type of oral cavity cancer is majorly OCSEC, that is squamous cell carcinoma type. The grade of tumor is referred to as differentiation of the cells. That means how similar the tumor tissue appears to be normal tissue from which it is originated. The grades can be given as G1, G2, and G3. G1 refers to well differentiation, moderate differentiation, and a poor differentiation. The well differentiated tumors are less aggressive, whereas poorly and moderately differentiated tumors are high aggressive. When we see pattern of invasion, the pattern of invasion of a tumor could be cohesive or non-cohesive. Cohesive means the cells migrate collectively, whereas in non-cohesive, the cells migrate individually by getting separated. That means the metastasis occurs of individual cells, whereas in cohesive, they metastasize collectively. The depth of invasion of a tumor in oral cavity can be seen like, for example, let's take this is a mucosal layer of oral cavity and this is a tumor which has developed in the oral cavity. Here the depth of invasion is the distance from the level of basement membrane of closest normal mucosa to the deepest point of the tumor invasion. This is the depth of invasion of the tumor. Then next comes the perineural invasion, which means involvement of any peripheral nerves, which means the tumor may develop into any of the layer of nerve sheath. Lymphovascular invasion refers to presence of tumor cells within the endothelium lined space. The bone invasion of a tumor can be of different patterns like infiltrative pattern, erosive, or mixed. Most of the oral cavity cancer are of erosive type pattern. Metastasis: the oral cavity squamous cell carcinoma majorly metastasizes to level 1, 2, and 3 lymph nodes of neck. This was about pathology of oral cavity cancer. Now let's see what are the signs and symptoms. The signs include presence of a non-healing ulcer for more than 2 weeks, persistent lymphadenopathy, lesion with pigmentation, persistent red or white lesions, and unexplained tooth mobility. The tooth become loose, whereas the symptoms include any sensory nerve deficit. It is seen when the tumor involves the nerve layers. Chronic otalgia, which means ear pain. Trismus of unknown etiology. Trismus means locked jaw, which is seen similar in the condition of tetanus. Then dysphagia, which means difficulty in breathing. This can be due to obstruction due to the tumor in the oral cavity. Dysphagia, which means difficulty in swallowing, which can be due to the obstruction by the tumor present in oral cavity. In the next video, we will come to know about the investigations and surgical management of oral cavity cancer. By this, we end up the session. Thank you all.